Advanced EMS considerations for the nurse executive is our episode topic. My guest is Dr. Jacob Miller, clinical educator and former flight nurse practitioner at UC Health Air Care and Mobile Care in Cincinnati. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Jake, thank you so much for joining us today.
Thank you for having me.
Our topic today is advanced EMS considerations for the nurse executive. And before we jump into the considerations of the nurse executive, I think first we need to define what is advanced EMS. So help me out a little bit. How is that different from regular EMS, I guess I would call it?
Advanced EMS is taking that to the next level and seeing what other things beyond the 911 response or interfacility transport can be accomplished by the EMS crews. And I think the other important thing when we're talking about advanced EMS systems is we're not necessarily always talking about using advanced practice clinicians, nurse practitioners, PAs, physicians. Some of these things may be able to be accomplished through regular EMS providers, EMTs and paramedics with advanced training.
When we're talking about advanced EMS, then is it hospital-based? Is it community-based or government-owned? Does it make a difference, or is it all the above?
Really all of the above. A lot of it's going to be dictated by the local practice model. Some states may have a model that more favors one versus another, but essentially this model can be implemented in any type of EMS system. A lot of it comes down to the local medical director, the local and regional protocol sets under which the EMS practitioners are operating, and then, of course, the state scope of practice. And that's where you may see the need to integrate higher levels of care, i.e. the registered nurse practitioner, PA, or physician, to accomplish some of the objectives. But in many systems, there are plenty of things that can be accomplished with a EMT and paramedic in the EMS system that would be considered advanced EMS, or could be considered advanced EMS, or perhaps just non-traditional EMS. Maybe it would be wise to take a step back and just define what advanced EMS is. And my conceptual model for advanced EMS is effectively doing those things that are above and beyond 911 field response and interfacility transport of patients. In some cases, it may involve 911 response or interfacility transport of patients. It may involve responding to the scene of an accident, or it may involve transporting patients that have incredibly high levels of acuity and healthcare needs. But this also encompasses other considerations, such as home responses for, I think a lot of the folks may be familiar with the terms community paramedicine, mobile integrated healthcare. That would, in my opinion, fall into this kind of advanced or alternative EMS model. Situations like that are ways that we can use our EMS resources to better patient outcomes, and it may allow them to stay at home and not have to come into the hospital in the first place.
Okay, so we're talking about both ends of the extreme here, really. We're talking about the really sick patients that may require a higher level of care from point A to point B, but you're also talking about potentially patients that don't end up going anywhere. There's a response, and then you leave the patient where you found them, so to speak, or maybe found them in a better condition. Am I summing that up accurately?
Yeah, I think that's exactly it. There's a wide acuity of patients out there, just as there are a wide acuity of patients inside the hospital and the emergency departments, in the wards and the ICUs. And we're really looking for models that can care for all of those individuals. On the low end of the spectrum, that may allow us to keep our patients out of the hospital in the first place. Some systems, some hospital systems, or municipal systems have implemented models where EMS, traditional EMS, the 911 field response, paramedic EMTs respond to the scene. They identify that the patient doesn't necessarily meet criteria for transport to the hospital. And in some systems, they may have advanced protocols. Unfortunately, the federal government has recently gotten rid of the ET3 model, which was the model under which they could be reimbursed for alternative destination transports by EMS. So it's going to be interesting to see where that goes. And that might be where this model may be helpful. But in some of those systems, they actually have a field response that is staffed by either a physician, a PA in some systems, or a nurse practitioner in other systems. And that advanced practice clinician is able to come out to the scene of that 911 call and then evaluate and provide a safe disposition for that patient without ever having them go into the hospital. And that is keeping the patients at home. It's freeing up the 911 assets because as soon as that advanced practice clinician gets on scene, that ambulance could go back in service. It's also decompressing perhaps some of the emergency department. We all know, I don't know that there's a nurse executive out there that would probably not be familiar with the term emergency department boarding at this day and age. That seems to be a pretty widespread situation across the country and internationally, in fact. So allowing those individuals to come to the home of those low acuity calls and provide safe dispositions, it may be something as simple as suturing or a prescription or just advanced diagnostics, perhaps ultrasound or other modalities, just advanced physical assessment, history and physical, and coming up with a treatment plan. Maybe it's linkage to care. Maybe it's reaching out and having that provider conversation with a primary care office and getting the patient a short-term follow-up. But having those resources available to those patients may be able to help keep them out of the hospital and help to decompress some of that lower acuity clog that we see in the emergency departments. On the high end of the spectrum, we have patients now with the regionalization of healthcare that are getting sicker, that are staying longer in community and tertiary hospitals, and then ultimately end up needing resources that are only available in tertiary or quaternary facilities. The classic example that I like to throw out there, one of the patients that I've actually transported was a patient who was prone on inhaled pulmonary vasodilators, going for extracorporeal consultation for an ECMO consultation, was on something insane, 15 different infusions, renal replacement therapy, all these different things, and we're being asked to move this patient. In many systems, that would be handled by a registered nurse and a paramedic. The consideration, though, is when those patients have such high acuity and potentially very dynamic needs, it may be beneficial to have an advanced practice clinician immediately available to that patient. Because especially if you're doing a flight transfer, whether that's rotor wing or fixed wing, those patients at 3,000 or 30,000 feet, you may not be able to access a physician for online medical control if you have questions about the patient's care, the patient's needs, if the patient's needs meet something that don't fit squarely into one of your protocols. So in those instances, it may be beneficial to have an advanced practice clinician immediately on the flight or ground transport to customize that patient's treatment plan to meet their rapidly changing dynamic needs over the course of that transport. Now, many of the interfacility transfers that we do, when you think about stroke, STEMI, even just sending someone from point A to point B for consultation of some sort, again, many of those are completely safe. They're being done by the regular EMS system in your region. And I'm not saying we need to change that, but I think that there are some patients, a subset of patients that would benefit from having that advanced practice provider or physician immediately available to them on that transport.
All right, so we've talked a little bit about the sickest of the sick patient population and also about what advanced EMS providers or teams can do. If I'm a nurse executive and I'm scratching my head, thinking while I'm listening to this, what types of questions or problems as an executive would I be trying to solve if I were looking to employ an advanced EMS model? Because I think it looks a little bit differently there from the what do they do versus what function do they serve? I know they transport the sickest of the sick, that got it. But Beyond that, what type of problem would I want to solve by instituting an advanced EMS program?
At the end of the day, it comes down to patient safety. We want to make sure that our patients are being taken care of in the most appropriate way possible. And that doesn't mean that it's inherently unsafe to not have an advanced model EMS system. But when you look at, for example, with our low acuity patients, we look at how many of those patients come into the emergency department, get lost into that sea of the waiting room. Some of those may have occult badness brewing in them. And we're not able to pick that up because there's so many individuals waiting there. Wait times are horrendous. The emergency department is boarding patients that need to go upstairs. And as a result, they're not able to move some of those patients through the waiting room. So being able to decompress that by preventing some of the patients, the lower acuity patients, getting rid of some of that signal and that noise, get some of those patients that don't need to be in the emergency department in the first place, either keep them home or have an advanced practice clinician evaluate them and come up with an alternative disposition. Perhaps they can go to an urgent care. Perhaps they can go to their primary care provider's office. Now, obviously, we're looking big picture here. Putting one nurse practitioner in an ambulance in one city is not going to have the systems level change that we're talking about. But if this model can be implemented widely, and if this is something that may show good outcomes, and the cities that have done this, Los Angeles, Baltimore City, and even I think it's Austin, Travis County has paramedic practitioners that are physician associates, and they are all doing this on a citywide level with multiple units. They've shown good outcomes in those cities for those populations that are the most vulnerable, for those patients who may not have access to care and they're using the 911 system, the emergency department for that access to care. Sending these advanced practice clinicians to those patients can be a beneficial step in decompressing the emergency department and linking those individuals with care or finding resources for them within the healthcare system. For those patients, it becomes safer. And then by potentially decompressing that emergency department, it can also lead to safer outcomes for the other patients who do show up to the emergency department because they're not trying to fight for the attention of the emergency department staff amongst all the other people who don't have as acute of a need for that emergency service. That's one end of the spectrum. And then for our high acuity patients, as I mentioned, the safety aspect there is that you have a individual who is able to formulate a treatment plan, has the legal authority to prescribe changes in the patient's therapeutic plan, whether that's pharmacotherapy, adjusting medications, adding medications, or just, other therapeutic options for that patient. And they're able to do that immediately in response to the patient's changing needs, as opposed to having someone that has to rely on protocols, which aren't horrible, but oftentimes in those high acuity patients, the patient will not meet the nice little box of the protocol, right? So they're going to have some dynamic changes. Many of those patients we know have multiple comorbid factors at play. So even though they may fit into one protocol, there may be reasons why you shouldn't actually follow every single step in that protocol. And just based on the patient's comorbid conditions and the patient's other considerations or other pathophysiology of their underlying disease state.
Can you give an example of this?
The perfect example that I give, and I've lectured on this at numerous national conferences, perfect example to that is a patient who's got critical pulmonary hypertension. We know that if that patient has severe pulmonary hypertension and right ventricular dysfunction, that some of our standard therapies for managing the patient, now they become hypotensive. We give a fluid bolus. That's great, except for the fact that may overdistend the right ventricle. We push vasopressors. That's great, except that there are multiple vasopressor receptors in the pulmonary vasculature, and that may worsen the right ventricular afterload. So all these things that we do by protocol that check the boxes on most of our patients, if you don't recognize that this patient not only doesn't benefit from that, but also may be harmed from that, that's something where you absolutely need to change that treatment plan to individualize it to that patient. And if you don't recognize that, and if you don't have the protocol to follow that, it may be challenging for a registered nurse and a paramedic to manage that patient safely in the transport environment without calling for medical control to get alternative orders for that patient. Whereas an advanced practice clinician can recognize that comorbid state, recognize the pathophysiology and say, okay, this is not what we're going to do. This is what the protocol says, but we are going to deviate from that on my authority, and here's what we're going to do instead. And we're going to do X, Y, and Z instead of A, B, and C. And in that case, that is a safer outcome for that patient as well, because we're able to immediately individualize the patient's care for them. We don't have patients in the hospital, on the wards, on the ICUs that are being attended without some sort of a prescriber, whether that's a physician, a PA, an NP, available to that patient. Doesn't mean that they're always in house 24/7, but there's always someone available to that patient. And while the theory is that that's the same case in EMS, right? Oh, they've all got medical control that they can contact. The reality is it may be very challenging to do that at, 3,000 feet, 30,000 feet, when the communications are very limited between that aircraft and the ground. And even on the ground transports, we're talking about dead zones and moving vehicles and trying to get a cell signal outside of a metal box. And it becomes very challenging sometimes to reach out to those medical control authority individuals.
Okay, so that's a lot of information. Let me shift gears here for a moment. Is it safe to assume, based upon the two different basic models that you've talked about, one for caring for the very, very sick, and two, looking at more community strategies of a community paramedicine approach, if you will, that those would be staffed by different types of EMS providers because they garner a different skill set need?
Yes, I do think so. So I am a former flight nurse practitioner, and in my role as a flight nurse practitioner, I had to be board certified as an acute care nurse practitioner. As far as the different types of board certifications for nurse practitioners go, I do think that for the high acuity, you absolutely must be acute care trained. But then for the lower acuity, that's not necessarily something where you need acute care training. Family nurse practitioners may be able to safely and effectively fill that role of the lower acuity responses, because we're looking at a different patient population. We're looking at a different skill set. Despite all of my training and credentials, I don't have the experiential requirements, in my opinion, to be able to safely say that, yeah, I can go take a job with Baltimore City Response Unit and go in and see patients and treat them in their homes. I think I could eventually get there with enough orientation and training, but right now, for me to just plug and play, I don't think that is the case. A lot of it comes down to the background, the experience, and the training of those individuals. Because regardless of what you're doing, chances are you're doing it with a fairly high level of autonomy. Even if you are in the field and have immediate access to online medical control, even for our paramedics and our nurses that are doing regular interfacility transport or 911 field response, they have to have a certain level of competency for that role that they're doing as well. Because at the end of the day, you can call medical control, or if you are a nurse practitioner, PA, physician, you can consult one of your colleagues by phone. They're not going to be able, this is not in the hospital where you're in the middle of a procedure and you're like, you know what, I'm not really sure what I'm doing. Let's get the attending over here to take over. That's not going to happen. Or if it does happen, it's going to take a while for that to happen. So you really do have to have a pretty high level of autonomy in that field where you work, in that area of expertise. I do think that really comes into play as far as the specific clinician that's in there. Now, I can't really set a blanket rule and say that these are all of the criteria for this type or that type. And there are some professional organizations that are starting to look at that and really trying to push EMS as a subspecialty of either emergency advanced practice nursing or a subspecialty of PA practice. We already know that EMS is a recognized subspecialty of emergency medicine by the American Board of Emergency Medicine. For the physicians, this is already a very well-defined pathway. And I think that we're starting to see some more advanced practice clinicians that are looking at that model and saying, okay, if this is a model for the physicians, maybe this is something that we should incorporate into our training to make sure that our advanced practice providers are able to function at this level as well and have the appropriate degree of education, experience, and training in order to go out there and practice autonomously. And that's not to say that I'm not trying to skirt the whole independent practice or whatever. I'm just saying that you have to be able to practice autonomously, whether that's with a consultation to a physician, whether that's without a consultation to a physician. That's going to be determined by State Board of Nursing, State Board of Medicine, those folks in your local jurisdiction. But certainly, regardless of what that legal practice authority looks like, you do have to be able to practice autonomously in that field, because that's what's going to be expected of you when you show up. You have to be able to perform the function. And if you have to consult someone, you have to consult someone, that's fine. But you are the one who has to be able to perform.
You were talking earlier about some of the changes about ability to bill for these services, particularly when they're not going to the hospital and that you can't bill for an alternative destination. I'm wondering more on the community side, because clearly this would not apply to an acute care transport. Thinking about the community paramedicine, low acuity type strategy of care, is it, obviously patient safety comes first, but is advanced EMS viewed, or should it be viewed more as a revenue opportunity for the organization, a cost avoidance opportunity for the organization, combination of the two? Where does the financial picture here fit into these types of programs?
That's the million dollar, perhaps billion dollar question. The problem with that is, unfortunately, there's really not a good way to generate revenue off of this right now. When you look at the existing CPT codes and billing codes and we'll just say that, for example, we're using a billable clinician, either a nurse practitioner, a physician assistant, or an attending physician who otherwise could bill for services. Because as far as the ambulance is concerned, per CMS, if the ambulance does not turn a wheel to transport that patient, there is zero billable charge. Ambulances are
Right.
unfortunately still viewed as a transportation benefit and not a treatment benefit. When we're looking at revenue, unfortunately, the CPT codes for out of hospital response or even interfacility transfer do not exist. And the problem with that is now you have a lot of systems that are looking at this and saying, we can't get paid for these services. So why would we put that person into service? I think that's where a lot of the models that are out there focus not so much on revenue generation, but to your point, on cost avoidance. Where when we have that nurse practitioner that is responding to the patient's home in Baltimore City or Los Angeles, or you have the PA that's on the truck going out to the homes in Austin Travis, and the other models that are in play across the country, that is focusing on keeping that patient out of the emergency department, because we want to be able to have the throughput of the patients that are in the emergency department, number one. And number two, what we see, a lot of those patients may also be individuals who have exacerbations of chronic conditions. And now we start looking at things, and especially when we look at the community paramedicine and mobile integrated healthcare, there's nothing to say that an advanced practice clinician, or using that model as an advanced model, those individuals can also, outside of the 911 calls, go to the homes of those patients who have high acuity, or not high acuity, but high risk conditions, your heart failure patients, your diabetics, those individuals that you do not want to bounce back because you don't want the ding from CMS and you don't want the financial penalties of that bounce back. You can proactively go out to those individuals where they are in the community and evaluate them and see how they're progressing, and make sure that they are not trending toward needing another admission, especially within that window of opportunity where it becomes a bounce back, that 30 days or whatever it is for that patient's disease state. Looking at those patients and try to proactively evaluate them in the community and keep them out of the hospital can be something that these individuals can do during some of that downtime. And now potentially the cost of implementing that model may pay for itself just in the avoidance of the costs of caring for that patient without the reimbursement later on, because it was a 30-day bounce back or whatever it was.
So we're really on the cusp of this emerging model, if you will. It sounds like there's a couple different places that you've mentioned multiple times that have different models that are out there, trying to find out the best way to deliver care. How do we get reimbursed for it? What does that look like from a revenue or a cost avoidance opportunity? I know that there's organizations that now have position statements out on this model too. Is that correct?
Yeah, correct. Most importantly, the National Association of EMS Physicians, NAEMSP, has authored a position statement, and I was one of the co-authors on that position statement. So this is coming out from a physician-based organization, but also with representation from nurse practitioners and PAs that are in the field performing some of these duties. And I think the other thing that we need to talk about is that we're talking a lot about direct patient care, but there's other things that those advanced practice clinicians can do, either with their time or while on duty. And that's highlighted in these position statements. So the NAEMSP position statement was the first one that came out, and then each of the professional organizations for PAs, so SEMPA, the Society for Emergency Medicine Physician Assistants, and then AAENP, the American Academy of Emergency Nurse Practitioners, each kind of came out with their own version, expanding on that within those respective disciplines and what those individuals may be able to bring to the table. So looking at the NAEMSP position statement, in addition to direct patient care, some of the other identified benefits of having an advanced practice provider may be to assist with protocol development, translating evidence into practice. We know that in the hospital setting, many hospitals employ DNP or master's prepared nurses to look at those clinical policies in the hospital setting. Exact same idea in the field. Taking that evidence, what is the best practice for 911 or interfacility, and implementing that into those protocols that those paramedics and nurses are going to be able to use. Looking at quality assurance and quality improvement, either running that QA/QI, assisting with chart audits, assisting with case reviews for the service. Certainly education and training, especially if you have that background. Many of the individuals, while PAs and NPs are not paramedics by definition, they are not EMS clinicians by most states' definitions. However, many of the individuals that are EMS, nurse practitioners and PAs, many of them have a background in EMS. Many of them have been or still are paramedics. I remain a certified paramedic, and I continue to work on average about one shift a month at the local fire department, practicing in the role of a paramedic on the ambulance, despite all the other things that I'm doing. Many of us are still active in that domain, assisting with education and training, whether that's assisting the physician medical director of the service or assisting the local fire chief or EMS chief to train those individuals within their department. Those are certain things that we can certainly do. Research is a huge opportunity in EMS. A lot of the things that we do in EMS are extrapolated from the emergency department or the ICU or primary care or some other domain because we don't have a ton of EMS specific research. If you have a DNP or better yet, PhD prepared nurse practitioner who's interested in EMS, that is an excellent opportunity to be involved and generate some of that research. So now when we have a podcast like this and we're saying, how does this work financially and what are the patient outcomes? We can go with hard definitive data and say, these are the outcomes. This is the cost benefit. These are the hard numbers because we've done this research, we've generated this data, and now we can actually show this is the benefit for this. Without that, I think that we're going to have a lot of speculation still, but certainly that is a role for those advanced practice clinicians, PAs, NPs, and physicians to be able to assist in that EMS system. And also, in addition to having that field response going out and treating the patients, in many locales, you may be able to also have PAs and NPs function as a medical control officer for field consultations. So when the paramedics have a question, rather than calling and talking to the emergency physician who's already swamped and 5 patients behind in the emergency department, they can potentially call and speak with one of the EMS, NPs, or PAs and have that consultation with them and potentially receive treatment orders from them. Certainly that would require authorization within that jurisdiction, whether it's the county or the state or whoever oversees that EMS would have to allow them to receive an order from an NP or a PA. And that's different from state to state, from region to region. But if they're allowed to do that, may be an opportunity. When I was working at one of my previous positions, just on the interfacility side, our ground critical care transport units would call the flight NP for orders on every single one of their patients. And this way, every single patient still received that individual care, and it was saving the physicians in the emergency department or the ICU or wherever that patient was going from having to make all these phone calls back and forth and trying to interrupt them when they're, because no medical control call comes at a convenient time. It's usually right when you're in the middle of a procedure or something that you can't step away from. So it was really a way to streamline and optimize that patient's care. So we were doing both triaging the calls and making sure that they went out for the appropriate level of care. And then we were also functioning as the medical control officer for those transports. Now, if we were on a flight ourselves, then they could call the physician medical director. So there was still that backup. It's not like we were out, they just didn't call anybody. So there was still that redundancy built into the system. But at the same time, they were not always calling the physician medical directors and waking them up or interrupting them when they were at work or on shift or out with a family gathering or whatever the case may be. That's another way that those individuals can be put into there. And that may be a way to improve provider satisfaction as well. The EMS providers are talking to somebody who knows what they're doing. They do the job regularly. And at the same time, you are also providing satisfaction perhaps to the physicians in the emergency department because now they're not having to get interrupted every 30 minutes, hour, 2 hours to answer medical control calls when they're in the middle of doing a bunch of other stuff in a busy emergency department. So that may be a win as well from a provider satisfaction thing. So there's a lot of other things other than just that direct field response. I guess that's a long-winded way to say that there's a lot of other ways to integrate these advanced practice clinicians into an EMS system. And when we're not out, because that's the other dirty secret with EMS, we're not 100% of the time seeing patients. It's not like in the emergency department where you always have someone in the bed or in the ICU where you always have beds filled. So when these EMS advanced practice clinicians are not actively seeing patients, they do have other things that could be assigned to them, whether that's protocol development, QA, QI, chart audits, education, training, medical consultation. Those types of things can all be integrated in there. And certainly if you have a community-based model, you can have them going out and visiting those high-risk patients in the community as well to make sure that they're not bouncing back into the hospital. There is a way to build some efficiency into here as well and assign multiple different tasks to these individuals and really optimize that system for an advanced EMS system.
Any closing thoughts as we wrap up this episode?
EMS is a growing specialty, and it's spanning well beyond that whole 911, you call, we haul transportation role that it was historically developed around. So I think that we need to come up with innovative ways to move that EMS resource, those assets, that system that's in place, and adapt it to the growing, changing needs of our healthcare population in the 21st century.
Jake, thank you so much. I appreciate your time today discussing all things advanced EMS considerations. I learned a lot. And for more information, for those of our listeners, please check out the NAEMS-P position paper out on the role of EMS, physician assistant, and nurse practitioners in EMS systems, as well as the American Academy of Emergency Nurse Practitioners position paper. Both of those are online. Jake, thank you so much.
Thank you for having me.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.